just focus on people's roles. So I'll start with Natalie Carfora here, who's our VP of Market Access. She just joined us, which is hard to believe, in August, given how much, as you'll hear when we talk, how much activity we've been generating. And she's fortunate enough that she showed up at just the right time, where we went from essentially no clinical utility data, which is sort of her currency that she needs to be able to engage with payers, to having a nice foundation for that. Next is Dr. Suman Verma, who is our Chief Scientific Officer. She's spends her time in our laboratory in Lake Forest, along with Martin Sasaki over there, who does the operations on the clinical side. So she's the scientist. She's the one who knows everything EsoGuard. I try to pretend I know a little bit. I go to these research meetings and I use a little bit of my, cobwebs in my medical training about it. But her team is unbelievable, and they've done things even with regard to this most recent advance in the assay that others have failed to do. And so we have an incredible research team that's continually looking to improve the assay and make it more efficient, make it more make the cost of goods lower, and then have Martin's team, who is also just incredibly efficient at getting things done. We'll talk about that in a little bit. Next we have Dr. Deepika Lakhani. She is our Chief Regulatory and Quality Officer. She spent many years at FDA, knows everybody there, can pick up the phone, can give us a lot of back channel chatter on all things FDA. And as you know, although EsoGuard is a laboratory developed test, we still operate in under the umbrella of what may or may not be increased FDA regulation. We'll hopefully have a bit of chance to talk about that. We're extremely fortunate to have somebody who has her level of experience and access to folks with regard to our regulatory matters. At the very end there is Dr. Victoria Lee. She's our Chief Medical Officer. I think Sean at least 3 or 4 times has already sort of given kudos to Dr. Lee, because as I said, we went from hardly any clinical evidence beyond the original STM paper to a substantial amount, and that's because we now have a functioning clinical research operation that can get those studies done and get them done at a high level of quality and a high level of efficiency. And we really do have to thank her and her team for that. With that, let's start with Dr. Verma. As we mentioned, and this is a little bit of opportunity for us to brag and for you to brag about your team. As Sean mentioned, we took over the laboratory in February of 2022, so we'll be at our 2-year anniversary. We acquired the CLIA laboratory. We have our own space in Lake Forest, a really beautiful space. And it was just around the time, a couple months before she started. And the assay has just really blossomed in our hands. I mentioned actually one little data point earlier where I pointed out that our sensitivity in our hands in the last 2 years with regard to esophageal cancer has been 100%. And so all of that is a reflection of Dr. Verma and her team. So maybe you could tell us and tell our audience here, maybe get a little bit into some of the nitty-gritty of all the specific things that we've been able to improve on the assay over those years and how it's had an impact on our outcomes.
Yeah, thank you. I think as Lishan said about the team, I'm really proud, I think, sitting here and talking about how much of an improvement on the EsoGuard test we have done. And one of the improvement that I would talk and brag about is, and Lishan talked about, is QNS rate. QNS, when we talk about, it's a quantity not sufficient, that's a acronym for it, means when a patient gets tested and we collect a sample by EsoCheck, the cells come to the lab and we extract DNA from it. If we don't get enough DNA to test the sample does get right away that we do not have enough DNA, we can't test it, either repeat the sample. So that's a high percentage of patients before we acquired were getting at that point that about 15% or so that patients were not having enough DNA. Once we acquired, now it's been more than a year, we are below 5% in that QNS rate. We improved significantly on the process of DNA extraction, how we are collecting, how we are improving, because that's very first step. If we do not have enough DNA, we cannot proceed the test. And I proudly state that we've been maintaining that less than 5% for over a year now. So that's a very proud. Second test, I think, in terms of the test efficiency of operations, it is key that when we acquired the test, it was an academic test, which can perform very, very well. But when you bring the test into a commercial settings, you need throughput, you need efficiency, you need fast turnaround time. And all those things need to be improved for the commercialization purposes, and that's what our team has done a phenomenal job on. We went on improving the processes that has allowed us to test samples in a high throughput. And Lishan very briefly mentioned about our turnaround time being less than 10 days, which initially was about 2 to 3 weeks when we acquired. We have brought that to successfully, within majority of the time, 7 days test. And so thanks to Martin's team, who is efficiently processing these samples in the lab, and to the research team who has improved on the processes, improved on the throughput of the test, where we have brought on the instrumentations that are able to increase throughput and reduce the cost, because now we don't have to spend that much time, or labor time has reduced, or cost of goods have reduced. So not only improve the operational throughput and efficiency, but also reduce the cost. And the last one that I would say very recently that we have done a press release on, that's EsoGuard 2.0 that we are very proud of, because this is something that previously our academic lab from where we acquired the test was unable to do, and our team has been able to achieve to do a multiplex testing of the genes, both the genes that we are testing, because it has a significant operational impact, robustness impact, that we are able to test the same sample in 3 times. We have enough DNA to produce even more robust results, more confidence on the results, and also operationally more efficient and reduce the cost. So I'm very proud to say that we have been able to achieve something that even Dr. Markowitz's lab was not able to achieve, so, and within a very short period of time. I think these all improvements just are testament to the commitment, the hard work, and the talent that this team has to overall provide a high quality test to our patients. So with that, I think I'm very proud, and we will continue to make these improvements and bring further costs down and operational efficiency for high throughput testing. And one of the very immediate improvement will be actually going to a higher throughput sequencer. And we actually are, as I speak, is getting installed in our lab right now, the high throughput instrument, and that which will bring even cost further down.
Great. Go ahead, Anthony.
So just to summarize, so the QNS, quantity not sufficient, has been brought down from about 15% to less than 5. So 1 in 20 don't have quantity sufficient. Is that probably the best you could do, and not necessarily what you could do, but is there anything else in the actual balloon that could be used to make sure you get enough of a quantity?
There's probably, let me just maybe quickly, there's probably some biologic limit beyond which you can't get that number again. There were, if you look at the BetaNet publications, there were sites that had 20 to 25% QNS rates. So it is a substantial lowering. Could we get down to 3 or 4%? Maybe, but we're probably reaching certain fundamental aspects of patients who have, you know, a so-called patulous G junction, where their G junction is not tight and you just don't make enough contact, and a variety of anatomical issues. So my guess is that since it's been quite stable and we have really, really high technical success rates, so we know that the procedure is being done properly in terms of being able to complete it, that we're probably butting up against the biologic limits of that. Yeah.
Just give a little bit more split on that less than 5%. When I look at that less than 5%, there is about 2% of the samples that we get almost 0, which shows it's anatomic, where the balloon is not making a contact, and I think those are very hard to improve. 1% or so which are just below enough, so 1 to 2% which are just below the DNA cutoff, where we could bring the test further down, but you wouldn't have the confidence. We want a very robust test. We have sampled enough cells. There is not enough cells to be confident on the results, and about less than 1% where there are technical failures in the lab, or tube got broken, or anything like related to lab processes or something that can happen, which is very, very less than 1%. But this is still unheard of, less than 5%, QNS rate, usually 10% is a cutoff for CLIA labs. So we are actually very proud of this.
Much better than normal labs. And just last thing,
Yeah.
The cost has been brought down, the cost. Is the 90% gross margin you're talking about, is that a target that you hope to get to?
Nope, yep, we're there. We're there on a next test basis. So if you take the total, the incremental cost, the variable cost of each test, and the cost of the EsoCheck device, which we still do a little bit of double sourcing and so forth, so we can even get that down on an average base a little bit further, that number is now below, low enough that we can comfortably say that we've hit that 90%, even at these volumes. Yeah, that doesn't obviously include the fixed costs. This is on a strictly marginal basis, next tested.
Right.
Yeah.
Thank you very much.
Yeah, great. Okay, oh, sorry, go ahead, Greg.
You said you're installing the technology to scale up. Where are you now? Where is it going to take you?
The next
Oh,
sequence.
so with the MySeq instrument, which is the sequencer instrument right now, we are able to do about 100 samples a week that we are running, and it will take us directly to more than 400 samples a week. So 4 times increase right away.
And the cost is actually reasonable. They have trade-ins and so forth. Illumina works with you. So
Yeah.
we were actually quite, I was pleasantly surprised at how that we were able to upgrade the throughput to the next seq with only a modest
What would it
amount.
take to increase that again?
We have plenty of capacity right now. Yeah, we're not going to be butting up against. One of the reasons why we needed to go to this is the spikes, right? Because we learned that quickly when we did our first firefighter event, when suddenly Martin and his team just got 400 samples, in a matter of a couple of days, and to their credit, they banged it out and got it done. But so we need to be able to have capacity to handle the peaks, which we will with the higher throughput device. But on a total test volume basis, on a yearly basis, we have plenty of room. And the same on the manufacturing side as well. We have plenty of room. We're not going to be butting up against that.
Yeah.
Okay. Great. So let's move on to Natalie. So Natalie, you're a yellow check person on my list. Did you notice that? I've already checked Suman's portfolio as being green, right? Because the lab is kicking butt. So you're one of the last 2 yellows. So I'm going to ask you about really to Greg's question. The near-term opportunities that you're working on with regard to some creative approaches on medical policy in our really well-defined population, such as CED and others.
So first I want to highlight that our opportunities and our discussions with payers are driven by the work that the clinical team has done in generating peer-reviewed published evidence around our clinical validity and clinical utility. So it's really exciting that we have this robust level of evidence to bring to them now and moving into the new year. A couple near-term opportunities that we're leveraging are, one, our recently executed agreement with the Blue Cross Blue Shield Association in order to leverage that to get access to Blue's payers in order to educate them. We're really going to be focusing on our peer-reviewed published evidence across clinical utility and clinical validity, as well as our guidelines inclusion in these national societal guidelines. And then in some states, about 14 states that have biomarker legislation, leveraging that legislation and how it supports both the utilization and coverage of innovative testing like ours. So that's one near-term opportunity. A second opportunity, which is what Greg asked about, was piloting, which is our focus on partnering with payers to validate the clinical utility of EsoGuard within their own membership, to use this data in combination with our peer-reviewed published literature, our guidelines, our provider utilization, and our successful prior authorization and appeals success record, all of that together to inform a broader positive policy decision. For some payers, this is going to be through a formalized structure called coverage with evidence development. And with others, it'll be through an informal structure. It really depends on the payer. Each is very unique and operationalized differently. But so when we say pilot, we can be using that interchangeable with coverage with evidence development.
That's great. So we'll look forward to that being a green checkbox at our next event next year. Really excited about that. And I'm going to go to Deepika next. So I saw some nods in the room when I talked about, among our analysts over here, when I talked about the fact that even as a laboratory developed test, we still operate under the possibility of increasing FDA oversight of our laboratory developed tests. And as I mentioned, obviously we're extremely proud to have you. I'll do a quick anecdote. When some of you know about this FDA proposed rule to phase out their enforcement discretion with laboratory developed tests, and Deepika will talk about that in a bit. But when I saw it for the first time, you read the title, it looks kind of scary, and I just quickly got on the phone and started making phone calls to people in DC that I needed to figure out what was going on. What I should have done is just calm down and asked Deepika to look at it over the weekend, and we had our ELT meeting on that Monday and realized that actually we're in good shape, and we feel really good about it, and as she'll explain, a bit of a positive. So without taking too much of your thunder away, maybe you can tell us a little bit about what your perspective is on this proposed rule and how we're positioned with EsoGuard to handle it if it comes to fruition.
Yeah, so FDA very recently has proposed a rule that LDTs may not be eligible for enforcement discretion, as historically has been the case with such tests. How does that impact us? So Lucid as a company is already operating under the highest regulatory standards because we have a FDA cleared device, which is the cell collection device EsoCheck. So we are not starting from ground zero just because we have a new EsoGuard that's now going to get regulated. Our quality management system is in place, so we have the umbrella set up for many years actually. We have been inspected. So we are very well placed to bring EsoGuard into the same umbrella of quality management system. Now, if this rule were to pass in the near future, there's another aspect of this, which is, so we have the quality system figured out. Now we also have to do a regulatory submission. What would a regulatory submission entail? It's basically the data that we are already collecting. It's the clinical validity and the analytical validity that the team is very aggressively and phenomenally collecting, and the data that you've seen today looks great. So this gets compiled into a dossier and gets submitted to the FDA. This is what the process is going to look like. And FDA has given multiple years to actually go in a stepwise approach. First, the quality system would get implemented, and we would have at least 3 years from the passing of the rule to submit our dossier with all the data that we have been collecting. So we are in great shape if this rule were to pass already because of our existing QMS, our quality management system. Having said that, I do want to be very cognizant of the fact that we have been able to address the unmet clinical need because of the LDT. So if this was not existent, this would not be looking like this because we would have to start from the highest regulatory authority and then bring the product to market. So we have all this great data thanks to the LDT and the regulations that we have been operating under. But now if we go under the stricter regulatory network, we pretty much have the data to submit in the time frame they would allocate to us. So another aspect of this would be that if we do go under the regulatory framework of the FDA's end of enforcement discretion, it would give us kind of a competitive edge because we have all these systems in place, the standards in place. Many companies may not have this who are our competitors. So from that perspective, I feel pretty comfortable about the journey we are on from a regulatory and quality perspective.
Yeah, and maybe a little bit of additional color. So I'm happy to serve on the board of AdvaMed, the trade association, so I get a little bit of visibility as to what the thinking is. I was actually in DC last week, and one of the points that Deepika made about even sort of sectors or stakeholders that are pushing hard for this acknowledge that that LDTs have been a pathway for innovation, just like us, that their concerns are more about sort of backdooring competitive tests and so forth. And so every construct that I've heard with regard to how this would play out does take that into consideration, the notion that you can't simply shut off the pipeline for innovation, and then there would have to be some consideration. There's lots of other factors, like FDA doesn't even have 5% of the resources to do this and so forth. There's a lot of details that'll need to be hashed out, but as Deepika says, we feel really confident in our position. Okay, so let's move on to Victoria, Dr. Lee. Look, I would love for you to give the audience here a perspective on sort of the inner workings of our clinical research operation, because it's awesome. It's been, the ability of your team to have sort of just really professionalized and generated high-level data, high-quality data, has been great. So maybe you could give a little bit of a flavor of what that looks like and the work that goes into that.
Happy to do so. So this ties back into something that Lishan's already mentioned, which is a lot of credit needs to be given to my teams. And I see teams in plural because we have our clinical research team who has done a fantastic job in regards to startup, execution, and beginning closeout of some of these studies that have provided data for Natalie's team to engage with payers. But then there's another team that also plays a critical role, which is our clinical services team, who now participate very actively in our PREVENT registries. So we are very fortunate to have teams of very talented individuals, hardworking individuals, who are able to contribute in multiple ways to collecting this real-world utility data. As for our clinical research team, again, I must say I'm very fortunate because they bring a lot of operational expertise to the company. And as many of you guys, if you're familiar with clinical trials, are aware, it's really the operational element that can make or break the efficiency in which you start up, execute, collect data, and then be able to close out these trials so that you have clean data to present in a usable fashion. And our team brings not just expertise in clinical trials with medical devices, but also with diagnostic tests. And this puts us in a very good position. We're very well equipped to continue with ongoing studies in the future. And the most exciting thing is that as we are forward thinking about these clinical trials that we'll continue to launch and execute upon, one of the things that we're excited to do is engage with payers, potentially these pilot programs, to make sure that the data we collect going forward is something that will be directly applicable to these positive policies.
Great. I mean, hopefully you get a sense of, of the intersectionality here, because what, you don't normally, at least in my prior life, wouldn't have thought of a clinical research operation. That's about just sort of the data evidence that whatever your product is works. But here's a good example. Not only do we need to have sort of clinical utility data that we generate ourselves, there's an opportunity for Victoria's work to intersect very tightly with Natalie's, because many of these pilot programs are effectively sort of custom clinical trials for clinical utility for that particular payer. And so because we have a highly efficient and effective operation, we can sort of snap our fingers and say, okay, great, what does this thing look like? Let's get a protocol in place and let's get rolling with this particular payer on a pilot program. So hopefully you get a sense of how the teamwork, how things are working well with regard to teamwork. Okay, I think we're tight on time, but we're going to do just a rapid fire, sort of corny. I think Sean wrote this, so I'm not going to take any credit for this, which is each of you. Why don't we go in the opposite direction? What are you most excited about for Lucid in this coming calendar year, 2024?
I think I touched on it before, but I'm really excited to now tie our clinical research strategy with our ongoing engagement with payers and have really clear direction as we move forward with collecting additional data.
Great. Deepika?
I think it's the ability to impact patients' lives that I'm seeing, and it's an opportunity for me to actually be bedside. Although I'm a regulatory person and a quality person, that touches me the most for this since I've been on the journey with Lishan and the team. So that for me is very exciting, the ability to touch so many lives in the future.
That's great. Suman?
For me, I think I'm very excited for the year 2024, where we will be able to test thousands of samples given the volumes we are seeing with the quarter, and hear many more stories like the story that we heard from Dr. Desvoli today, that makes my heart feel that our test is making impact in real world. I
can assure you that sentiment from the two of them is up and down, from people in finance to people in the lab, people who don't have direct necessarily intersections with what we do. That sentiment that we're waking up every morning and doing something strong, powerful is quite consistent. So.
And I'm really excited to take all of their pieces together and package it in our engagement with payers, because we have the provider utilization, we have all this new evidence, we have guidelines, and so it's really going to be an exciting time, a busy time in 2024.
That's exactly right. Busy is a good way to close this out.